Hello, everybody, and welcome to Macro Pro and Friends webinar series. Today, I'm joined by Michelle Taylor. Michelle, how are you doing?
I'm good. Diane, how are you?
I am fantastic. Speaking of Diane, I guess I should tell everybody I'm Diane with Macro Pro, and it's my pleasure to put on this webinar series on behalf of Macro Pro. So, can you tell us, Michelle, what it is that you do for your company? And it's
Yep,
got
of
a new name,
course.
right? You got a new name also at the company.
Yes, we did. We changed our name late last year. So, hi, I'm Michelle Taylor with Heads Up Healthcare. And thank you so much, MacroPro, for having us. This is wonderful. And thank you, everyone, for joining us today. Um, yes, as Diane mentioned, we went from Dental Works to Heads Up Healthcare, and it's been about a year now. It's been fantastic, actually. We've added a couple more services. This is the reason why we went from Heads Up. So we've added eyes and ears in addition to teeth. So we are going to be adding also ENT. We're still building out the network for that. So you can send us some ENT referrals, but we are, like I said, we are still building out the network. Like I said, my name is Michelle Taylor. I cover the Western region, and I am your rep if you have any questions in regards to your dental claims, vision or ENT or, or audiology.
All right.
Diane?
So, Michelle, you and I have something in common. We're kind of quarantining right now because we're not feeling well. So,
We are.
we're
Yeah,
looking
we
forward.
both. I have the flu. I went to the doctor's yesterday. I was in urgent care, and they tested me, and I tested positive for the flu. So I'm quarantining in my office for a week, and Diane is under the weather as well, and she's quarantining in her office. So I hope
So,
you all are safe and healthy.
yeah, well, webinars are great because we can't spread any germs to anybody. So, Michelle, before we get started, is there a holiday tradition that you guys do every year? Is there something you're looking forward to?
Yeah, absolutely. So normally this time of year, if I wasn't under the weather, we would be, well, we are planning, it's just being postponed. We usually take a trip to Big Bear with my boys, and they go snowboarding, and the three of them together. I don't snowboard. I just financially, my husband and I, we pay for the boys to snowboard, and we watch, and it's a great memory for the family. So that'll be coming up after Christmas. But that's always a great tradition that we do every year, and I'm looking forward to it in the next coming weeks.
Great.
And that's, yeah, a fun tradition that we have. Do you have any traditions, Diane?
I cook a big prime rib dinner and have all my family come in on Christmas Day. So that's kind of the big thing that we do. So before we get on with our webinar, I'd like to just do a little bit of housekeeping. So the first thing is today's webinar is with one California CEU. You must be logged on to GoToWebinar using the link that they gave you. If you simply just phone in, unfortunately, there's no way for them to record your time or attendance. So make sure that you are using that link and on a computer for them to be able to do that. You can download there are handouts, and you can download those right now so that you have that to follow along with and or have for in the future. You will be receiving your CEU in 1 hour after this presentation. Please make sure that you download them as soon as you get them. They don't stay on the GoToWebinar platform forever. So if you wait, a few months, it may not be available to you. So do it immediately. And then lastly, if you have any questions you'd like to ask of our expert, there is a question spot. You can ask that question, and then Michelle and I will ask our guest speaker about the question and on your behalf. Excuse me. This week I'm a little bit sick. And the last thing is, if you'd like to see a replay of this, it will be on the Macro Pro YouTube channel, so be sure to watch that. And one thing about medical is there's always a need for records. So if you need those records for anything that Michelle's company is doing for you, Macro Pro can get those for you. So Michelle, can you introduce your guest speaker?
I would love to. Yes, today we have Stacy Haynes. She's with Heads Up Healthcare. Stacy's been with our company. There she is. She's so beautiful.
Hello.
Stacy's been with Heads Up Healthcare for right around 7 years, and she is our clinical director. She reviews every single treatment plan that comes across her desk, and she is a great asset to our team. Stacy, take it away.
Hello, everyone. It's so great to be here with you guys today. Thank you for listening in, and wanted to introduce myself. I've been with Heads Up Healthcare for 7 years. However, I'm 28-year surgical tech, and mostly in the oral and maxillofacial arena. So hands-on to surgical procedures and cosmetic surgeries. But what I do mostly here with Heads Up Healthcare, I review all the treatment plans that come our way, making sure that the treatment is appropriate, and reading the clinical notes, teaching the team here how to read the provider notes and their scribbles. So before, okay. I'm not able to change screens here.
Maybe you try your up and down button.
That's what I'm trying. There it goes. Okay. Okay. So the insights I'll be sharing with you guys today come from over, like I said, 25 years of working in the dental and oral and maxillofacial surgery arena. And of course now, we manage various types of dental and oral facial work comp claims. So I'll be sharing a lot of what I spend my work days doing to review and analyze. And yes, we even scrutinize work comp claims just to make sure that the recommended treatment is appropriate. You guys, if you've had any dental injuries or worked any of these type of dental claims, if you're not commonly, if you don't do these on an everyday basis, and you don't have common knowledge of dental procedures and so forth, then, you get lost, and you just really, it can be very complex and a lot of movement with work comp injuries. So we'll get into it much more as far as the movement of work comp claims. To me, managing any work comp claim, not just dental, can seem like a game. And the reason I like it to a game is because there's the challenge. The challenge to get the injured worker to MMI, the game rules, there's money, unfortunately, real money, not play money. And you often can get stuck, and
I hate to interrupt you. I hate to interrupt you. Did you advance your screen? Because we're still looking at the first screen.
Yeah, I did. You're still looking at the first screen?
Yeah, the first slide.
Okay, I'm on. What are you seeing anything now?
I'm just the welcome slide.
Oh my goodness. Okay, mine's switching, mine's changing, but yours is not.
That's correct. There we go. We see a new slide now.
Okay, now mine's not changing. This is the weirdest thing.
It worked perfect in practice.
It sure did. Okay, what about that?
Yep, we see objectives, common dental injuries.
Okay, it's working for me too, so we're good. Okay, so let's go back to objectives. We're going to start with objectives. So hopefully today, by the end of these next few minutes, I'll be able to help you become more familiar with the most common dental injuries and the probable treatment, be familiar with the different dental specialists and their scope of treatment, have a better understanding of the motion of work comp dental claims. Any trauma that impacts an employee from the neck up is likely to involve a dental or jaw injury. For example, car accidents, construction or manufacturing accidents, slips and falls, falling objects, just to name a few. But here are the most common dental and maxillofacial injuries that we see and deal with on a daily basis. Number one, fractured or chipped teeth, dislodged teeth, knocked out teeth, which we refer to as avulse, damaged crown or bridge work, fractured jaw, TMJ, which we called the temporomandibular joint disorder or dislocation of that joint, nasal or facial bone fractures. Our most common dental injury, I would say, is fractured or chipped teeth. At least 80% of the referrals that we get are fractured, chipped teeth. The main objective with any damaged tooth, though, is to know one thing, the golden question. Is it going to be a repair or a replace? Can the tooth be repaired or does it need to be replaced? It's just like the tires on your automobile. You're driving down the road, your low tire light comes on, your tire may have suffered some type of injury. You pull into a tire place, you want to know if the tire can be repaired or you want to know if it's going to have to be replaced, right? So, well, the same thing here with an injured tooth. Many times, though, it's just not real easy for the general dentist to know the answer to this golden question alone without further evaluation by specialists, such as an endodontist, which is a root canal specialist, to check the internal health of the tooth to see if the tooth may need a root canal. I don't know if any of you out there has ever had a root canal, but that's dealing with the internal portion of the tooth. And this is critical because knowing the internal condition of a tooth goes hand in hand with knowing the outer condition of a tooth. Same in medical. If you're in a car accident, it's equally important to evaluate if there are any internal damages, right, in your body. So that's why they, send you through the appropriate scanning and so forth to see and determine that. But once internal testing is completed, it may be that a root canal is necessary. Let's focus a minute on a root canal procedure. What is it and why would it be needed? I know it carries a horrible reputation, but when the nerve inside of a tooth is compromised by trauma, the pulpal tissues become inflamed and necrotic, and the nerve starts to die. A root canal procedure is a procedure of removing and cleaning out the nerve inside of the tooth, and it's intended to eliminate infection and provide protection from future bacterial invasion. It's simply an attempt to save the tooth. It's important to also understand that once a root canal is done on a tooth, it will most likely require a restoration of some type, either a filling or a crown to strengthen it for long term. If you had a root canal, I bet you either had a filling on that tooth or a crown. And that's to strengthen it long term, because once you take the nerve, the blood supply out of a tooth, it can become very brittle over time and causing the tooth to be more susceptible to breakage. So that's why they do that. And in the beginning, it's not uncommon for an injured tooth to appear to be internally unaffected at first, and then there sometimes weeks or months down the road, symptoms arise. A dying nerve can many times be a slow death process and resulting in the need for endo, which endo refers to end of root, which is endodontic treatment, which is root canal treatment. At some point in the future, it's always a possibility for a period of time after a tooth has taken trauma. But whether a tooth structure has been damaged or not, meaning it's chipped or fractured, either a composite filling or a full coverage crown, or even perhaps a veneer sometimes will be recommended, depending on the amount of tooth structure that's missing. And those are our only options available to repair an injured tooth. So that's what this slide is about. The internal treatment, which always first has to be determined, and then your outer structure of the tooth will either get a filling or a crown, of course, depending on structural damage. Our next most common dental injury is dislodged teeth. As much as teeth are chipped and fractured, they can also be dislodged by intrusion, which means pushed up into the socket or partially avulsed, knocked loose from its socket. In such cases, a procedure called wire stabilization can be done until further evaluation and treatment can be determined. But repositioning the tooth back in its proper position and stabilizing it is an immediate need. And it doesn't always save the tooth, but it is at least an attempt to allow the tooth time to recover to see which direction it's going to go. And most of the time, teeth that are knocked out of position, subluxated, they will require most of the time root canal treatment just because of the nerve within the tooth being compromised. In many cases, teeth are knocked out completely from work accident, avulsed. If so, then of course replacement of the tooth is necessary, which will then cause us to move from a treatment plan of repairing a tooth, like we looked at, to a treatment plan of replacing a tooth. When a tooth needs replacing, let's look at what our options are. For a healthy mouth, our two main options to replace a tooth is either a bridge or an implant. And we'll go over the differences here. Let's look at the bridge option first. What is a bridge? A bridge literally bridges the gap of the missing tooth by connecting a fake tooth to the teeth on each side. A bridge is a fixed device, meaning it cannot be taken in and out because it's cemented permanently. You can see there in the diagram on the slide, a bridge carries a 12 to 15 year life expectancy. The good thing about a bridge is that it can be completed in 2 or 3 weeks, treatment done. Only drawback in work comp is that it adds responsibility for unrelated teeth. And the reason is because you have to trim down teeth on each side of the missing tooth in order to bridge everything and secure the bridge tooth. So if something goes, bad with those teeth down the road, then the whole bridge, you're dealing with 3 teeth or more. Whereas if an implant is a treatment option, then that's a standalone advantage that you have. So I always like to point that out, but because if given options, we like to go with the better option long term. Not to say a bridge is never a good option, but we do a lot of bridges. But, if we're given an option, let's go with the better option for us, right? The next common dental injury we see is damaged crown and bridge work. When there's crown or damage to existing crown or bridge work, replacement of the crown or bridge is required. But the first thing that has to be examined and determined is the condition of the natural teeth underneath that is supporting the crown or bridge. Most of the time when a crown or bridge gets damaged, the supporting teeth underneath are also damaged. And if so, the teeth may need root canal treatment to help save the teeth, or it may be determined that the teeth are damaged even beyond repair and they have to be removed, which usually will then result in an implant treatment plan. Either way, the crown or bridge prosthesis will need to be replaced. The question is just to what extent? And of course, that's depending on the damage to the supporting tooth structure underneath. Often with treatments such as fillings, crowns, and bridges, a preliminary dental cleaning will be added to the treatment plan. You'll see this because, and I know you may ask, why am I having to pay for a dental cleaning? Isn't that supposed to be the patient's responsibilities? And I completely understand. Yes, in a perfect world, everyone would have nice, clean, healthy teeth when they get injured, but unfortunately, that's just not the case. And this is anyone, even if you or I, have been inattentive to our oral hygiene and our routine dental cleanings, and there's plaque and calculus or tartar present. Before a restoration procedure can be done in our mouth, such as crown or bridge, we'll just simply have to have our teeth cleaned, plain and simple. Cleanings reduce the level of bacteria present, which helps eliminate the risk of infection following the procedure. And it also reduces the amount of gum bleeding into the impression materials that have to be done in order to fabricate the prosthesis. And in many cases, even a deep cleaning and scaling is necessary, and depending on the degree of the oral hygiene condition, because we just cannot expect a dentist to prepare a tooth for a nice crown or bridge, or God forbid, and place an implant into bone, and there is bacteria everywhere and the gums are bleeding. So we watch for that, and we're on top of that. But whether a tooth has been knocked out completely or it's been determined that it cannot be saved and needs to be extracted, there will obviously be left a hole where the tooth was, right? If the tooth is being extracted, bone grafting material is usually placed into the socket. And the reason for this is to restore the anatomic tooth structure of the anatomic bone structure and preserve the bone volume and height for whatever replacement option is chosen. And I wanted to show you this slide because it entails taking the tooth out, sprinkling, I call sprinkling, putting the bone grafting material in it, and then placing a barrier on top, and then, you know, sealing it up with some nice, the gum tissue up with some nice sutures. But the socket is preserved by placing bone grafting. It's like filling up a hole in your yard that you've taken a bush out of. You don't want a big divot in your yard where people fall and trip. So you fill the bone, you fill the hole in, and so when you come back later and put something there, uh, you'll have a nice foundation. And there's no guarantee as to how well the extraction site will heal and fill in naturally if we did not do this procedure. So that's why it's become standard these days, because it's just a guarantee, pretty much guaranteed to have a nice foundation to come back and place a bridge or an implant in. So let's look at the other option for replacing missing teeth. It's the dental implant option. What is a dental implant? It's simply a titanium root that's implanted into the jawbone, and it's only the root portion of the tooth, because later a custom crown is fabricated to attach to the implant. Good thing about dental implants is their lifespan carries 30 plus years to the lifetime of the patient, and the 96 to 98% success rate is wonderful. And that's, I mean, that's statistics, and that's even if patients are not the best with their oral hygiene, because natural teeth don't decay. You know, they can get a little periodontal disease around, but implants do not decay. Natural teeth decay. So that's, you know, contributing to the success rate here. Like I mentioned earlier, implants carry a standalone advantage, which is great in work comp industry, because you're only dealing with the one missing tooth or whatever number of teeth that has been damaged at the time of the injury. So you're not paying for unrelated teeth that in the future can go bad, and then you have to stick with that. And once you own them, you always own them. So that's the beautiful thing about implants in work comp. Before going further, though, I want to discuss a couple of procedures that are commonly requested when it comes to trauma, and one is reconstructive bone grafting. After trauma, sometimes there's left extensive bone deficiency to the alveolar ridge, which is the bone that our teeth sit in. And a lot of times, because of trauma, this bone has to be reconstructed in order to restore the bone structure and contour to replace the tooth. It's also known as alveolar ridge augmentation. This particular bone grafting here in the image is different from that average socket preservation graft into the hole where we just saw on the slide. This is advanced onlay bone grafting to the higher segment of the alveolar ridge. This happens to be a block graft, but that's because there was a lot of deficiency in the bone and it had to be filled in. Another augmentation procedure that is often done in trauma cases, because placing dental implants is so common, is sinus augmentation. Now, of course, this only refers to the upper back teeth, because maxillary sinuses are located directly above and close to the upper back teeth. There are no sinuses underneath the lower teeth. Low-lying sinuses has nothing to do with poor or dental hygiene or anything like that, but only has to do with the patient's anatomy. The sinus floor may be too low to place an implant, even on you or I. So a T-disc procedure that gently lifts the sinus floor up, places the bone grafting material in underneath to obtain adequate vertical height to come back later and place the implant. So let me just say that the effects that these necessary bone grafting procedures have on the survival of implants is significant, according to all reviews and studies. They just simply work. So when I see them come across on, look at the x-rays, then I know that it's definitely legitimate and called for. But now we're going to get into the more challenging treatment options. Not so much the treatment being challenging, but determining what the best treatment option is for each individual patient. Every case is different. We're going to look into denture options for replacing lost teeth. We'll first discuss the removable denture. It's a removable partial denture. And that's because when the condition of the mouth is not ideal for a bridge or an implant, like would be for a patient with healthy oral conditions like you and I, removable partial denture usually is the first option that comes to the dentist's mind. A removable partial denture is a denture that partially replaces lost teeth. That's how it gets its name. You have an injured worker who's lost 4 front upper teeth. A removable partial denture is an appliance with the 4 upper lost teeth on it, and that when you insert it, it clasps onto surrounding teeth to hold it secure. This option requires healthy and stable teeth, though, because it attaches. That's how it keeps its balance. That's how it stays secure, is that it clasps to the surrounding teeth. So if the surrounding teeth are not healthy, if they're all deplored with decay and periodontal disease, and they're loose from bone loss, then you have a whole nother picture. But that's why a lot of times in a treatment plan with a partial denture, you may see non-related teeth being recommended to have treatment, and that's because the doctor's trying to get those teeth up to par to be able to serve as anchors for the partial denture that he's going to make to replace the lost tooth or teeth from the industrial accident. It is the most economical treatment plan for a missing tooth, I must say, but it is also, of course, the least desired because it is a removable appliance. A lot of times you don't, a claimant will not want this particular treatment option because they didn't have anything removable before. They're not used to taking something in and out of their mouth. They just sometimes don't settle for this particular treatment plan, but it is definitely an option in some cases, not in every case. But a dentist will always decide what the appropriate treatment plan is based on these factors alone. What is the injury? What is injury related? First and foremost, number 1. Number 2, the current condition of the mouth. Number 3, the age of the patient. And number 4, the treatment necessary to return to pre-injury status. Nothing more, nothing less, right? So first and foremost, in your review, you must find out what the provider is identifying as related to the work accident, what teeth numbers and the damage that was done to them as a result of the work accident, right? We all know decay would not be considered damage from any kind of accident. However, if the tooth is broken off, even though there may be decay present, there is a possibility the accident caused the tooth structure to fracture. Even more probable in cases of decay, because decay weakens tooth structure and makes the tooth more susceptible to breaking off. So this can be even more challenging for providers in work comp because of the set perimeters in work comp. We all know that work comp is not the lottery. So staying within the guidelines of only treating what is injury related and getting the injured worker back to pre-injury status are the 2 main objectives. However, providers are also faced with having to consider the age of the patient, as well as the current condition of the mouth and how those factors also affect the outcome of treatment. When a dentist is determining the appropriate treatment for any patient, not just work comp, the important factor of the current condition of the mouth must be appraised. There's just no way around it. It's the ABCs of dentistry. For example, you have an injured worker who's knocked out 4 front upper teeth and the rest of his surrounding teeth are in very poor condition. The condition of the surrounding teeth matters a whole lot, like I just explained. If there are no surrounding teeth suitable to render any kind of support for the usual replacement options to replace the lost teeth, like would be for a patient with moderately healthy mouth, then the treatment plan changes from that of someone with healthy teeth and gums, because ordinarily, as we just talked about earlier, a bridge or removable partial denture, and in some cases dental implants, would be the replacement option for a patient with a moderate healthy mouth. But if the condition is to a deplorable state, an all-out sinkhole, a bridge or a partial denture is just not on the table. The dentist is also considering the age of the patient. He understands that a patient in their 30s or 40s wearing conventional dentures over a long period of time will just result in severe bone loss in a matter of a few years, even to the point where implant supported dentures will eventually not be an option for this patient. So he's having to look at what is best long term for the patient, and we are too. We who are having to foot the bill, and we can certainly appreciate that as well. So when you have an injured worker who has neglected their mouth and they have severe periodontal disease, rampant decay, multiple missing teeth, an all-out sinkhole scenario, and now they present with damaged teeth as a result of the work accident. The current condition of the mouth is a major factor when considering the appropriate treatment for this patient. And believe me, we are on it. We look at these cases, we go back and forth on alternative treatment plans. Every case is pretty much a puzzle. We have to put the puzzle together, put the facts together, analyze it, plug in alternative treatment options, and see what's best for the patient and for us as well. So with our guy who's lost his upper front 4 teeth, the only other replacement option there may be for this patient, as I mentioned, are dental implants. But think about it. Would we park a brand new Mercedes in a falling down garage? Of course not, because placing implants amongst disease and erosion is not a viable option either, because the dentist is not going to set anyone up for failure, especially himself. This is the point in time that the garage will need to be torn down so that new construction can be done. That's how it's done. You know, no different than a building that's been condemned. That's how it's done here in dentistry too. In these cases, it's necessary to get all the bad teeth out so that a healthy environment can be established to replace the lost teeth and restore function with some type of denture. Otherwise, you would just be throwing good money after bad. Plus, it would not be ethical. Provider would not be willing to participate in substandard treatment. So the best thing to do is remove all the bad teeth and look at what denture options there are. So here we are with no other options than full complete dentures when the patient has to lose all of their teeth. There's no teeth that can serve any kind of anchor for any kind of prosthesis. So we have to get all the bad teeth out and pretty much start with nothing. At this point, when patients are in this type of situation with their teeth, they were just a few months or a few years away from dentures anyway. Unfortunately, the work accident has caused the necessity of immediate treatment prematurely. So let's look at what our full denture options are. There are 2 categories of dentures in these type of cases where poor oral conditions are to the degree that all of the teeth have to come out. They are conventional and implant supported dentures. Now, in work comp, we have to analyze and examine the factors that exist that are dictating the medical necessity of a particular treatment plan, right? By using the process of elimination, we get an understanding of what is actually an option for the patient. It's what we do all day, and what option is not. So before we just sign off on the most elaborate implant-supported denture that exists, we review the factors that are playing a major role in determining the best treatment option for this claimant. Conventional, which are just your regular traditional dentures, are fully removable dentures that are placed after all the teeth have been removed and out of the way. They are held in place by adapting to the jawbone ridges, using the tongue's ability, of course, to hold them in place with denture adhesive sometimes. That's why it's vitally important to have adequate bone volume to be able to wear this type of denture. Adequate bone means having healthy bone ridges that keep the denture from moving around and falling out, because who can chew when your dentures are moving around? So, only thing is that a major drawback with this conventional denture, because this type of denture rests on the jawbone, the bone tends to resorb over time by taking a continuous pounding of the chewing forces, that the dentures become more and more loose over time, which means multiple relines and refabrication. Because once bone is gone, it's gone. There's no getting it back. That's why when we talked about the age of the patient, that's why these particular type of dentures is not ideal for younger to middle-aged patients. But as with all denture types, the dentist will need to determine if the patient is a proper candidate for a removable conventional denture such as this, and has the adequate bone to hold the denture in place. That's your traditional dentures. The other denture category is an implant-supported denture. And there's no question that implant-supported dentures have many long-term benefits. Of course, That is if the patient meets the criteria for implants once all the teeth have been removed, which is can be a whole nother factor. But implant supported dentures are, as the name suggests, it's where implants are inserted to support a denture. They are the recommended treatment of choice for many different reasons, and good reasons actually, such as for the injured worker in their 30 or 40s, too young to have to resort to a conventional denture, even for the injured worker who has no bone left due to the ravages of periodontal disease and is unable to wear a conventional denture long term, or a patient who has taken offensive medications for a long period of time and their teeth have deteriorated from a condition that we call xerostomia that we see a lot, which we'll discuss later. And I know you may be thinking, why should we pay for implant supported dentures? Because Mr. Claimant neglected his mouth for years and now doesn't have, the adequate amount of bone to wear regular dentures that are less costly. And I completely understand, because like I said, these are the battles that we fight every day. And all I can say is that after we've analyzed and we've determined that that is actually implant supported dentures is the best treatment option, is I usually just say, let's look at the big picture here. Do we fight for the least costly treatment plan, or do we look into the future and decide what the best prosthetic solution is long term? Do we wait until Mr. Claimant has no bone left and all of his bone, now we've paid for years of refabrications of dentures to only come back, like I said, years later and still have to put implants in. So it's, do we do it now? Do we do it later? And sometimes it's a gamble, but that's why we look at the case very closely. We consider all of the treatment options and what factors are playing a role in that treatment recommendation. So let's get to xerostomia, because we just touched on this. What is xerostomia? It's probably the first time you've ever heard this word. And it's simply a dry mouth condition. It's usually caused by offensive medications. It's the absence of saliva flow. I want you to also understand that it's not a disease, but it is usually because of the overuse of medication. And the big drug offenders that cause xerostomia, dry mouth condition, are narcotics, antidepressants, opioids. But why is it a problem? Believe it or not, saliva is one of the most important biological factors in our bodies. When there's not the proper amount of saliva to wash away the acids that build up in our mouth, the teeth will decay and erode. Fluids in every part of our body is vitally important. We all understand that dehydration can be deadly and is considered what I think they call it the silent killer. And the same with dry mouth in our mouth. Our teeth, it's deadly. If we don't have saliva washing away those acids, then our teeth will erode to the point where all of our teeth will have to come out. And depending on what stage or severity the xerostomia condition is, will determine the treatment plan. If it's in the beginning stages, usually a provider will usually first try to crown the teeth as they go bad, get the patient on a good preventative maintenance plan in hopes to slow down the erosion, as well as maybe some saliva stimulants to help the production of saliva. But still very possible that in time, all of the teeth will need to erode to the point of needing to be removed. It's an ongoing struggle and challenge for the injured worker to keep up superb oral hygiene habits, keep the mouth moist as much as possible. It's just not a good situation for anyone. I always like to bring in the fact that when I first started working here at Heads Up Healthcare, I call it my Lincoln Project. I got a treatment plan on a gentleman for, it was like $68,000. When I looked into it, he had already had 2 or 3 rounds of full mouth crowns, and we were well near $200,000 already. And here I'm getting another round of crowns, and I'm like, whoa, 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 wait a minute here. So I looked into it and I realized there's got to be an alternative path. So I got on the phone with the prosthodontist, and I coerced her into getting Mr. Lincoln on a path of implant supported dentures. Well, he doesn't want anything removable in his mouth. Well, at that time, it was a little before the better fixed implant supported dentures came out. They were in the process of them coming out. They came out. We got him on that path. So as the teeth started going bad, she started removing them, placing implants, building a roadmap for some nice dentures to go on top of the implants that were fixed and did not have to be screw in tight, where they, didn't have to, he didn't have to take them in and out. But anyway, all in all, we got him on a good path, got him into implant dentures. His xerostomia condition had no effect on that. So that's the ultimate goal, because ultimately the teeth wobble, the patient's not going to be able to keep up with the erosion, because once they start eroding and decaying, the deterioration goes very, very fast. So moving on, facial fractures, the next on the list of common injuries in work comp. As you know, blows to the face and jaw are usual occurrences in the occupational world. Prison guards, security officers, automobile accidents, caretakers working with combative patients, of course, your falling accidents. There are two types of facial fractures: your mandibular fracture and your maxillofacial fractures. Mandible meaning lower jaw, maxilla is the upper jaw, which involves the cheekbones, the orbital floor, and the nasal bones that extend even into the palate and upper alveolar ridge that holds the teeth in place. But the green circle on my image identifies mandibular fracture. The lower image underneath is a surgical fixation of plates and screws in the maxilla. Like any fracture, as you guys know, if you've ever had a broken arm or a leg, treatment is always determined by the severity of the fracture, right? There are two classifications of fractured bones. They are stable and unstable, like an arm or leg break. A stable fracture will heal on its own with just having the brace to keep it from being able to move, just keeping it immobile. Same thing with a stable jaw fracture. Conservative treatment will be recommended for the jaw to be wired shut for several weeks so it cannot move while the fracture heals. So, on the other hand, we all know an unstable fracture will need to be surgically set and fixated by using plates and screws while the broken bone heals. So moving on to our next common dental injury, and yes, I would say common, because TMJ injuries are more and more common. But what is TMJ? I know it gets a horrible name, and it's so funny to watch our adjusters, because when they hear the word TMJ, it's like they're thinking of some kind of disease. But TMJ is nothing more than our temporomandibular joints. We all have them. There are jaw joints, like a knee joint. Our jaw joint that functions like a sliding hinge. The TMJs connect the jaw bones to the skull, basically. The problem comes is when the jaw is impacted, which is whiplash at the time of trauma, or a problem can even occur with the TMJs because of post-traumatic stress causing an involuntary parafunctional grinding or clenching habit we call it bruxism in oral and dentistry and oral and maxillofacial surgery, that the injured worker may be doing and not even being aware that they're doing. In their sleep, a lot of times this happens, and this can cause severe inflammation to the muscles and joints. This is considered a TMJ disorder. I hope none of you that's listening has a TMJ disorder, but it is a common disorder these days as a result of stress, any kind of parafunctional grinding or clenching habit. A lot of times I've heard, everybody grinds their teeth at some point or another. Stress can cause that. Yes, for sure. But I'm talking about here where there's a sure diagnosis of a disorder. Oftentimes by taking a jaw lash, the occlusion, which is the way our teeth come together, becomes abnormal, out of alignment, which of course in turn places tremendous stress on the muscles that are surrounding the joints, therefore causing a lot of pain. And this misaligned bite causes the muscles to become inflamed and the intense jaw pain that comes with it. The good news, though, that if caught early on, treatment is usually successful with just conservative management over, a few months. If not treated early, though, the treatment can take longer, of course, and be more invasive and costly, to the point of complete joint replacement. Now, in my 28 years of working in oral and maxillofacial surgery, I can really count on one hand that we had total joint replacement of the jaw, of the TM joints. The conservative treatment and management works wonders if the patient follows through and obeys and does their part and what they're supposed to do, wear the bite splint and follow through with treatment. But usually the first order of treatment is conservative managed. Like I said, a nighttime or daytime or both types of bite guards are fabricated. That's depending on the way the doctor wants to treat and the malocclusion. It's also called orthotic splint therapy. They're just removable devices, sophisticated appliances that, when worn, help align the bite and relieves the pressure off the joints. Of course, then allows the muscles to relax and recover. And then once the inflammation reduces, the pain goes away. Doesn't mean that it can come and go. They maybe will feel better for a while and quit wearing their bite guard, and then months down the road, things are heating up again and things are becoming sore. Then they have to go back into the bite splint for a few weeks. But depending on the extent of injury, bite therapy extends over usually a period of 3 to 6 months on average, and it may be in conjunction with physical therapy or some type of therapeutic injections. I like to explain bite splint therapy in the same sense as any other kind of brace, because the goal of any type of brace is to give support, right? Whether it be a neck brace, a leg brace, it's fitted to something to hold it secure. Likewise, an orthotic bite splint is designed to keep the jaw joint secure in a certain position, help realign the misalignment, reduce the biting pressure, therefore ultimately relieving the stress off the inflamed muscles surrounding the TM joints so that they can recover appropriately. There's your night guards, orthotics. A lot of times injections to the joint area is done, even Botox, because Botox paralyzes the muscles. Therefore, you paralyze someone's painful muscle, it's going to feel better, right? For 3 months. Usually, you have to, it'll either do the trick, or you have to come back 3 or 4 months later if pain and do a little bit more. But usually Botox therapy works wonders for a long period of time and can cure the problem. Occlusion, let's talk about occlusion real quick, because occlusion refers to the alignment of our teeth and the way they come together. It's a very important factor of our dental health and can cause a lot of issues if it is even in the slightest out of alignment, which we refer to as malocclusion. With all dental treatment, whether it be fillings, crowns, bridges, or a fractured jaw, our occlusion is one of the biggest and most important factors that is being checked during any dental treatment, believe it or not. That's why when you have a filling done or a crown done or a bridge, that when the dentist gets that crown seated, he's putting that little carbon paper in your mouth, little piece of carbon paper, and having you to move your teeth around it. He's capturing the way your teeth come together. He's making marks on your teeth so he can see if you're over occluding on that. Because if you are over occluding, then that porcelain, or that whatever that most of the time is going to be porcelain, that porcelain is going to fracture, or that filling is going to fracture, the implant could fracture. Number one reason for implants failing, guess what? It's occlusion, over occluding. A malocclusion can be a result of fractured jaws not healing properly, jaw lashes, and even developmental malformations. If the malocclusion is to an extensive degree and orthotic bite splint therapy, like we just discussed, does not make the necessary correction, then possibly orthodontic treatment would be recommended. Now, that means putting braces on the teeth to move the teeth around so that a proper bite is established. And then our last resort, which would be a very invasive surgical approach, would be orthognathic corrective jaw surgery, where they actually break the jaw, break or re-break the jaw to get the proper jaw alignment that way. But just keep in mind, it is most important to have a proper occlusion and not a malocclusion. All right, so now we're almost done. I'll have a little fun here. Let's play a little game and run a real life scenario that we see all the time. Let's say a dental claim has come about. We have an injured worker who's fallen from a ladder. Possible jaw fracture, some fractured teeth maybe. What's our first move? Keeping in mind that broken bones always takes precedence over broken teeth, we'll first seek evaluation for the suspected jaw fracture, right? This is because of the risk of infection with broken bones. With trauma that consists of possible broken bones, most likely the injured worker will be evaluated in some type of emergency room setting or a care center first. And the priority at that time is, of course, to confirm if there are any fractures and whether surgery needs to be done. And then the teeth can be evaluated later. But in our game, let's say our injured worker, he suffered a lower jaw fracture. They determined that it was fixated by the oral surgeon even at the hospital. But now the oral surgeon has released the patient to be evaluated for the broken teeth. The general dentist will be the one who we need to evaluate the teeth. Why? Because he's the gatekeeper regarding teeth. I like to refer to him as the general contractor because he'll evaluate the teeth, he'll give a general diagnosis and direction for further evaluation if needed. If he directs care to the different specialists. If he needs to call on the plumber, the oral surgeon, the electrician, which I compare to the endodontist because he does root canal, the internal, then he'll do so accordingly. So we look to the general dentist to be our general contractor. I'm going to quickly go over with you real quick the dental specialists and how quickly they can all become involved even on one case. There are 5 different types of dentists that have expert training in dentistry. Actually, there's 6, but since pediatrics is not a player in work comp, we'll leave the pediatric dentist out of this. But in our case, surgical fixation, like I said, was done for the jaw fracture by the surgeon. Now, the general dentist evaluated the teeth, but needs the endodontist to determine the internal health of the teeth. But let's widen the picture a little. Let's say there is periodontal gum disease that's playing a role in whether the teeth that are injured are even worth saving because of gum disease. Keep in mind, the injured worker's mouth was wired shut for 6 weeks after surgery. The periodontal condition declined. So a periodontist is needed now to evaluate the periodontal condition and determine whether teeth are saving or not. As you can see, 3 of the 5 specialists have already been utilized on our one case, and that was very quickly. But let's keep going because the picture can get even wider. The broken mandible, the broken jaw has left a bad occlusion. Remember the bite we were talking about, the way the teeth come together? The bite is off. Surgeons try their best to get the fixation perfect, where the teeth come together like they should, but all fractures don't heal perfect. So let's say now we're having locked jaw, we're having TM joint, muscle stress and spasms, jaw clicking. Patient's got to go back to an oral surgeon or an orthodontist. Orthodontist is all about the alignment of teeth, so we'll go to the orthodontist to get him to look and see what he can do, maybe put braces on, move the teeth around to get a proper alignment. That's better than going back and re-breaking the jaw, right? So you can see real quick how things can get very complicated. Sometimes a prosthodontist is even pulled on board to crown all the teeth, because you can crown teeth and form them any way you need to get that proper bite. So like I said, it can get very complicated real quick on a case, more complex, broken bones, but we have to be on guard. We're always, analyzing, looking out, because 70% above the neck injuries result in overutilization. You probably already know that. Delayed return to work, unrelated costs due to lack of specialized clinical oversight. But that's what we do. And we always recommend, when you get a claim, to act immediately. we try to we recommend steering away from the patient going to their personal dentist, because a lot of times, unfortunately, things that's been needed for years gets thrown in on the work comp claim. And if you're not, savvy in dental, you don't really know the difference. But so we just say, be on top of your game early on. Don't wait until receiving a bill. Like I said, before acting, we don't want you to go into bankruptcy. So we are done at this point with our presentation. Does anyone have any questions that you would like to ask?
I see one question. It says, is there a general rule for determining reasonable cost for any given procedure? Thank you, Kevin, for your question.
A general rule, there's not a general rule, but because every provider's costs are different. Our network providers we could give an estimated cost of treatment once we know the diagnosis, and we know the possible treatment options. If a tooth is fractured or malocclusion, then it's a little bit more complex. But if we know a tooth is chipped or fractured, we can give a pretty darn close good estimation if we know the area of what the overall treatment could be. Yes. A general rule, I don't know of a general rule. You just have to have the information. You have to have the information to know the diagnosis and the probable treatment that we just discussed.
Yeah, because we have our in-network pricing, and then there's the out-of-network as well, and the out-of-network would fall under like a personal dentist. We don't have any control over their pricing.
Correct.
Thank you. Excellent question.
Excellent question. But if you utilized us with the care and management of the claim, then what we could do is tell you up front what our network pricing most likely is going to come out to be. But like Michelle said, if it's an out-of-network provider, we could just give a general census as to what the fees could be as high as.
Well, ladies, I want to thank you so much for joining us today. Do you guys have a final thought by chance? Something you'd like to leave everybody with, a thought or?
No, I just wanted to take the opportunity and thank everybody for participating today. We greatly appreciate it. And thank you for your time. And Diane and MacroPro, thank you so much for having Heads Up Healthcare.
It's our pleasure.
It's been a pleasure, Diane, meeting you. Talking to you yesterday, your practice was fun. Appreciate you allowing us to present. It was very, very good opportunity.
Well, there was some really great information. I think we don't think about all the complexities of a mouth injury and any pre-existing condition that the mouth is in. So you brought up some really good information for all of our attendees. This is our fourth presentation of the 12 days of CEUs for Christmas. So join us tomorrow for our next one. And I hope that you all have a great evening. See you tomorrow. Bye-bye now.
Merry Christmas.
Happy holidays. Bye-bye.
Bye-bye.